All right. So yes, I am an addictions therapist, and I am a tobacco treatment specialist also. And I'm also an acupuncture detoxification therapist. So what that means is if any of you start to get rowdy or act out during the presentation, I will come out there and needle you. And you will actually get very relaxed and feel very good, because that's what acupuncture detox does. There's a weird thing about it, though, when you're training, because you know where acupuncture detox is done? What part of the body? It's on the ears, right? Do I have any fellow acupuncture detox specialists in here? But it's done on the ears. There's actually 5 points. There's a little kind of flat spot right here. If you put your finger in your ear and it feels kind of smooth. There's 5 acupuncture points there: the heart, liver, lung, kidney, and something called the Shen Men, which is sort of like a prime meridian. And when you stimulate those points with these very small, sharp needles, you get this sense of relaxation. But when you're training, you become very interested in ear anatomy. So when you're standing in the checkout line at the supermarket, you are staring at people's ears, and oh, that's a good acupuncture ear. Oh, that's not a good acupuncture ear. So sometimes you get a little funny. But I want to reflect a little bit on the first 2 presentations, and I want to kind of get reoriented, maybe in a mindset. But I want to thank Dr. Savage for doing most of my presentation for me today. So when I get to those parts, we can go quickly, because I'm the one that comes right before lunch, and I know people get very, very serious about their lunchtime. So I'll go over that pretty quickly. And Dr. Carpenter, for explaining exactly how tobacco treatment should be done, using that motivational interviewing type of approach. So as most of the people, do you know, and I want you guys to kind of shout out answers, all right? Because I'm going to ask you some questions as we go. But do you know, of all the people who smoke or use tobacco, approximately what percentage of them have expressed a desire to quit? I heard, yeah, high numbers, and that's right. About 70% of people who smoke have expressed an interest in quitting. In fact, from the period of 2011 to 2013, almost 60% of smokers in Maine actually had a serious quit attempt. So this myth that people don't want to quit is actually not true. And we hear that all the time. They don't want to quit. But there's a difference between not wanting to quit and being ready to quit. So if you ask 10 smokers, are you ready to quit? How many of them are going to say yes? About 2 of them. So what Dr. Carpenter was talking about is motivational interviewing and using that approach, because the people have a lot of ambivalence about quitting. They have reasons to quit and reasons not to quit. So using that approach is really going to help them. The other thing I want to ask you, because we're sort of focused on opiates and opioids today, I want to ask you, what is the more serious addiction? Is it heroin addiction, or prescription opioid addiction, or is it tobacco addiction? Which one is more serious, do you think? People are thinking, that's a trick question. What's he going to do with that one? Well, let me put it in perspective a little bit. I don't know if anybody counted up the 2 slides that the Dr. Savage had up there on deaths related to opiates and heroin, but I counted it up to be about 40,000. So 40,000 overdose deaths due to heroin and prescription painkillers. Do you know the number of smoking-related deaths per year in this country? You know what that number is? It's about 500,000. It's approaching 500,000. To put that into a little bit of perspective, right? If 3 747 jumbo jets, fully loaded, crashed every day for 1 year, that's about 500,000 people. Now, I wonder, would you be upset if 3 jumbo jets were crashing every day, killing everybody on board? I think there'd be a sense of outrage about that. But we kind of look at it differently. There's a lot of talk, and I'm not minimizing at all the opioid problem. It's a serious problem and people are dying. But I'd like us to be able to put these 2 disorders in the same silo, right? Because there's no difference between these addictions. They both act exactly the same way. in the brain. In fact, one of my slides is exactly the same as one of Dr. Savage's slides. But I want you to think about that. I mean, you think about the fact that almost 500,000 people die of smoking-related disease. What's the number one killer disease in the country today? Heart disease, right? Heart disease followed by cancer, smoking-related diseases, COPD, other respiratory diseases. That's where the deaths are coming from. And here's a factoid. If we could eliminate smoking, what percentage of lung cancer deaths would we eliminate? What do you think? 90%. If we could eliminate smoking, we would get rid of 90% of all lung cancers. But if you look at the harm caused by tobacco, there's 13 or 14 different kinds of cancers. There's a number of other chronic diseases that are tobacco related. So kind of the bottom line, and what I hope you leave this talk with, is the idea that these other substance use disorders and tobacco are kind of inextricably linked, and that they need to be dealt with at the same time, right? We need to have concurrent treatment for substance use disorders and other tobacco use disorders, and I hope to prove that to you with some of the stuff that I'm going to show you. So let's see. So a couple objectives. We're going to look at some of the things that link tobacco and other substances together. We're going to look at some comorbid use and the effects on the brain, some changes and impairments, and then some treatment approaches for co-users of tobacco and other substances. Does this look familiar? This slide is exactly the same one that Dr. Savage used, and it's exactly the same pleasure pathway that nicotine affects. So there's no difference between the two. So, and here's another little factoid. You've heard probably the term smoking cessation a lot. Stop using that term, all right? Because what does cessation imply? If you're going to cessate something, what are you going to do? You're going to stop, all right? Would you tell a person addicted to heroin, oh, we're going to put you in a heroin cessation group, oh, we're going to give you a cup of methadone, and then we're going to do a brief intervention, 3 to 10 minutes, then we're going to send you on your way, and you're going to be fine. Would we ever think of doing that? Absolutely not, all right? So what we're doing with tobacco is we're treating it. We're treating tobacco use disorder. It's not tobacco cessation, it's the treatment of tobacco use disorder because of what's happening in the brain, because it's exactly the same mechanism as any other drug. So you guys recognize this? DSM-5, substance use disorder diagnosis criteria. Is there a different set for tobacco? No, these are exactly the same, all right? 11 symptoms exactly the same for most substance use disorders. Sometimes for some of the hallucinogens, there might be a different set, but one of these might be eliminated. But there's absolutely no difference in diagnosing tobacco use disorder and other substance use disorders. Now, those of you familiar with the DSM, what did the DSM-4, how did that list this particular disorder? What did it say? Anybody remember? For tobacco, it said nicotine. It said nicotine dependence and nicotine abuse, the way we used to talk about it in DSM-4. In the DSM-5, it says tobacco use disorder. Does anybody know why that was changed? Why tobacco didn't appear in the DSM-4? Think tobacco industry. Think tobacco lobby. They did not want the word tobacco appearing in the Diagnostic and Statistical Manual of Mental Disorders, right? But the crew that put the DSM-5 together included it. So now I think it's more reflective of what it actually is tobacco use disorder. So 2 to 3 symptoms is mild. 4 to 5 symptoms is moderate. And if you have 6 or more, you have a severe substance use disorder, severe tobacco use disorder. Can anybody pick out 6 of these that apply to tobacco? Because most people have a severe tobacco use disorder. For example, loss of control or inability to stop, that fits. Persistent desire, unsuccessful efforts to stop. Craving, a great deal of time spent. Using, continued use despite physical or psychological problems caused or made use. And withdrawal. One thing I really like about DSM-5 is we put craving in there. Craving was not a symptom in DSM-4, and all of us know that it is a symptom of craving. It's a physiological symptom, so I'm glad to see that's back there. The biopsychosocial model, which was mentioned in a slightly different way, all substance use disorders are biopsychosocial illnesses, so there's a physical part to it, there's an emotional part or a psychological part to it, and there's also a social part. And you can't treat a substance use disorder without addressing each one of these areas. You can't just throw a medication at it. What do people who try to stop smoking, if they're going to use a medication, sometimes they'll just go out and buy Nicorette, right, and they'll chew the gum, and that might alleviate maybe some of the withdrawal, but what are they doing about this mental health issue, the psychological part of it, this guilt and the shame and the emotions that they have about it? And what are they doing about the environment that they're living in their work site, in their home, and their peers? All of these things need to be looked at and need to be addressed. And those of you who are in substance use disorder treatment, if you're here, you know this, right? You know you just can't look at one of these realms and have a successful treatment outcome. So the biopsychosocial model is looking at all of these areas together and incorporating that into a treatment plan. So a little bit about genetics. What the research shows is that genes are responsible for about half the risk for alcoholism and other addictions. So it's possible to hypothesize that there are common or correlated genetic factors that increase the risk for both tobacco use disorder and other substance use disorders. And it's kind of interesting because individual differences in tobacco and other substance use are partly attributable to genetics. Some studies have demonstrated that the same genetic factors responsible for substance use also play a role in the development of impulsivity and conduct disorder, as well as the general propensity to all drug use and misuse, sensation seeking, and general problem behavior. So genetics plays a big role in substance use disorder. So what I want to do is look at a couple of the connections between tobacco and other substances, and I chose 4. So we're going to look at cannabis, alcohol, stimulants, and opioids. So let's take a look at tobacco and cannabis. All right, what are some of the connections? Tobacco users who are also cannabis users are more likely to be daily users of tobacco and more likely to develop tobacco use disorders than non-cannabis users. Also, tobacco smokers who experiment with cannabis are more likely to progress to cannabis use disorder than non-smokers. Using data from the 2009 National Household Survey on Drug Use and Health, it's estimated that the probability to develop cannabis use disorder was more than 8 times greater in tobacco users than in non-tobacco users, and that the probability to develop tobacco use disorder in cannabis users was 3 times greater than in non-users. In other words, if you're a tobacco user, you have an 8 times greater risk of developing cannabis dependence. And if you're a cannabis user, you have a 3 times greater risk of developing tobacco dependence. Okay, I'm going to throw this question out to you in terms of, let's stick with tobacco, all right, and not cannabis here. But what do you think about this? Look at our banner on the bottom of this slide. Is it a safe option, to smoking? What is the number of chemicals produced when you smoke a cigarette? How many chemicals are in that tobacco smoke? Anybody know? About 7,000 chemicals. And about 70 of those are known carcinogens. Right? What do we know about the vapor in these electronic cigarettes, these ENDS devices? What do we know about it? We know it has nicotine in it, or you could put THC oil, I suppose, in there as well. This vapor that's produced is produced by heating propylene glycol and vegetable glycerin, a mixture of those two, and then infusing that with nicotine, and that's what's inhaled. So propylene glycol is a food additive, and the FDA has said that it's relatively safe as a food additive, but what we don't know is what happens when you heat it up and turn it into a vapor. We don't know how that affects the lungs. So the answer to this question is don't know, right? Now, what if somebody said to you, just out of curiosity, I want to stop smoking and I want to use acupuncture, or I want to stop smoking and I want to use an electronic cigarette. You know, what do you think you should say to them? I'd say go for it. I'd say go for it, because that motivation that Dr. Carpenter's talking about, there's a motivation there to stop, so you really have to kind of strike while the iron is hot. But the other thing I would say, in addition to that, is and remember him talking about giving information and asking permission to give information? The other thing I would say is there are some evidence-based methods that we know work. We don't know if e-cigarettes work. We do know that acupuncture doesn't, by the way. It's one of the other reasons I mentioned that earlier, is there's really no evidence that acupuncture alone can help people stop smoking. And we don't have any evidence that electronic cigarettes can. But we do know that other things work. We do know there's 7 first-line medications that work. I'm going to touch on those in a little bit. We know that practical counseling works in helping people stopping smoking. So I would share that with them. But this we really don't know. But if you have any clients that use e-cigarettes, one of the things you might want to share with them is there's very little evidence that shows they're helpful in people stopping smoking, number one. And that most people who use e-cigarettes also use combustible cigarettes. They just go back and forth. So they're really not reducing the nicotine level. They're just using 2 different kinds of products. And maybe, I'm sort of a harm reduction person, so maybe that's better. I don't know. I mean, I'd much rather have somebody use an e-cigarette than a regular cigarette, because I know there's 70 carcinogens and 7,000 toxic chemicals in the regular cigarette. But the jury really is still out on it. But also, if you look down at the bottom, you can see that little bottle. And that's the e-juice, and that can contain maybe up to 750 milligrams of nicotine in that bottle. And that's what they put in to heat up. And does anybody know what the toxic dose is for a child of nicotine? It's about 4 or 5 milligrams. And look at the bottle. Would that be attractive to a child? You think it might be. So if you have any clients that use e-cigarettes, tell them to treat this e-juice like medicine and make sure that it's safe and make sure that it's put away someplace. Anybody know about these things? These are like brand new, right? Just wanted to kind of share this kind of factoid with you about these brand new products. Heat not burn, tobacco products. So that little white thing goes inside this cylinder and it heats it up. And you can get a vapor, almost like a smoke out of that, but it doesn't burn. And the tobacco companies are touting this as a safer method to use tobacco. Not that we don't want you to use nicotine and get addicted to it, but here's a better way to use nicotine. Here's a better way to feed your addiction. You're not going to get sick this way. E-cigarettes are sort of the same kind of way. But I just wanted to make you aware of this new trend, and you'll probably hear a lot more about it. There's a lot of trials going on now. Okay, what approximate percentage of adult cannabis users, we're getting into some connections, also report that they use tobacco? 78.3%. So there's a big connection here, and you're going to see this theme in every drug I talk about. You're going to see the same type of theme. There's a huge connection between tobacco use and other substance use. And for the substance use disorder people in here, when you ask your client, when you use cannabis, do you also co-use tobacco? 99% of the time they're going to say, yeah, I use it together, or alcohol, or cocaine, or heroin for that matter, or other opiates. There's a really strong connection between these 2 things. And they're working in that same area of the brain, that pleasure pathway, that dopamine pathway, that very primitive part of the brain. And if you stop one and you don't stop the other, what do you think the likelihood is of relapsing to that other drug? It's going to be higher, right? It's going to be higher because that pleasure pathway is still activated, it's still lit. So concurrent use, as I said before, stopping both of these things at the same time is preferable to doing it one at a time, or doing it, one in a row, for example. Now, when I was training to be a counselor The people that trained me were mostly people who had come out of AA. And I'm not disparaging AA at all, but they were telling me to do the wrong thing. They were telling me never, ever tell someone to stop smoking and stop drinking at the same time, because they'll be too stressed. They're going to relapse to their alcohol. They're going to relapse to their drug of choice. And I caught on to this a little bit later in my career about drug of choice. You guys have heard that term? What's your drug of choice? I like heroin, or I like alcohol, or I like cocaine, or whatever it is. If you're willing to give up alcohol, but you're not willing to give up tobacco, what is your drug of choice? Your drug of choice is nicotine, all right? So what's interesting, though, I want to just share a little data about cannabis smoke and tobacco smoke. Is cannabis smoke as dangerous as tobacco smoke in terms of lung cancer, do you think? It's actually not. There really is not research that connects lung cancer and tobacco smoke, or cannabis smoke. Now, there's a whole bunch of other negative consequences that you can get as a result of using cannabis, respiratory issues, and all that kind of stuff. But there really isn't a lot that shows a damaging effect as far as lung cancer goes. In fact, it might even be helpful in terms of like an anti-inflammatory sense. So what happens when people use nicotine? Lots of good things, actually. It works by stimulating the release of dopamine and other neurotransmitters, as you can see. But dopamine is the primary active agent, as with most other psychoactive drugs. So it's not difficult to understand how once a person is addicted to nicotine, they can also become addicted to the enhancing effects of the drug. So eventually the person is unable to experience these positive effects in the absence of nicotine. Nicotine becomes the coping mechanism, and the person can't function without it. So the way that most people try to stop using tobacco or stop smoking, what do you think it is? Cold turkey, right? Anybody know what the success rate of cold turkey is? It's about 3%. It's about 3 to 4%. Because of this, because of what we're talking about, because of the effects of nicotine. I kind of really liked that little exercise that he did, you know, because I don't know if anybody got really shocked in the end when he said, the thing that you love the most is going to kill you and kill others around you. I didn't see that coming, but I really felt the emotion there. And when you talk about nicotine, you talk about other substances, that's the emotion that the person is experiencing. That's what you're asking them to do. You know, think about a person who is a smoker, and here's a good example. I have a colleague at the Center for Tobacco Independence who's an ex-smoker, and she said to me, I hated smoking. I hated smoking because it ruled my life. My whole day was revolved around my smoking and my cigarettes. I had to get my dose of nicotine. But at the same time, I hated it. I hated it because of those exact same things. So remember that ambivalence that the doctor was talking about? You know, there's really good reasons on one side, really good reasons on the other side. But you cannot successfully stop using tobacco probably without using a medication. And that's when we're going to talk about opiates in a second too, and it's the same way, you know, with opiates in terms of medication-assisted treatment. And this is the reason, because of what happens in your brain. So some of the compelling characteristics of nicotine: it relaxes and stimulates at the same time. It rewards are consistent and predictable, so people know exactly what's going to happen when they use their nicotine. Does this sound like other drugs also? Anybody getting this? You could be talking about anything up there, Ed. Effects occur quickly after use. Now this is interesting. We've kind of edited this one out to talk about impairment as well, but lack of intoxication or lack of impairment. And I think this is why people tend to put tobacco, nicotine in a different box than they put heroin and they put alcohol. Because what happens when someone gets drunk, or they use too much heroin, or they use too much cocaine, there's an immediate acute effect, right? You don't see that with nicotine. Where do the negative effects occur with nicotine? They occur later. They occur down the road. So when you think about it, other substances are more of acute addictions, and tobacco is more of a chronic addiction. But in people with serious mental illness, for example, high rates of smoking, by the way, in the mental health population and also in the substance use disorder population. So anybody know this statistic? How many people, what's the percentage of people in Maine who smoke? Overall, because it varies from county to county and place to place, but overall, if you put it all together, what's the percentage of people in Maine who smoke? Yell out some. Good yelling, excellent. Somebody said 20, they're closest. 19%. Raise your hand. Perfect, okay. 19%. What percentage of people who have substance use disorders and mental health disorders smoke, do you think? It's more like 80 to 90%. I saw one study that had people with schizophrenia at 100%. And one of the reasons I think that that is true is because we addictions counselors, in our practice wisdom, we're telling people not to stop smoking. In fact, you should probably smoke more. Then you're not, you won't be drinking if you smoke more. And people on the mental health side of things, we're telling people, hey, this helps your symptoms. When you smoke, don't you feel better? Yeah, in fact, there were some economies in some of these mental health inpatient facilities. The economy was all based on tobacco. If you behave, and if you come to group today, you're going to get your smoke break. Right? So we actually encouraged the use, and I said in the beginning, we figured out that 70% of tobacco smokers want to quit. Do you know what the percentage is among people with mental illness and substance use disorders? 70%, right? So I had clients talk to me and say, yeah, I wanted to stop smoking, but nobody ever asked me if I wanted to. Nobody ever told me or gave me any help or gave me any advice on it. So part of that is on us. So one of the things that I want to encourage you to do is have that conversation with your patients and with your clients. Don't assume that they don't want to quit, because most of them do. And the reason that the rate of quitting is so dismal is because they don't use evidence-based practices. And does anybody want to tell me what evidence-based tobacco treatment is? It's pretty simple, right? One is providing counseling to people, practical counseling. How to deal with stress, how to deal with risky situations, how to deal with a family member who smokes, that type of thing. What's the other element of evidence-based counseling? Practical counseling is one. What do you think the other is? Medication, right? Every person who is trying to stop smoking should be offered tobacco treatment medication, right? There's very few contraindications. It's very, very safe. Nicotine does not cause cancer, as some people think. It should not be used in one particular group. Does anybody know what that group is? There's one particular group where using nicotine replacement therapy is not such a good idea. And that group would be pregnant women, because nicotine can be teratogenic and can cause birth defects. So behavioral counseling is indicated in that group. But that's evidence-based practice, right? Using tobacco treatment medication and providing practical counseling. And not a lot of providers actually know what the evidence-based practices are. So how did the client find out? So we have to educate ourselves about what those evidence-based practices are and then share that with the clients. And one of the other things about nicotine is no perceived immediate side effects, right? When you think about alcohol or heroin, you can die from withdrawal, from alcohol withdrawal. You can die from heroin overdose. Those are pretty serious, immediate side effects. But with tobacco, there don't seem to be any, other than the person might experience mild withdrawal if they don't smoke for a little while. So that's another one of the reasons that we tend to separate those two things out and not consider tobacco in the same bucket with other addictions. So what are some of the links? So shared genetic risks, we know that. All the environmental, behavioral, and social cues common route of administration and gateway drugs. And I'm talking about now kind of specifically cannabis and tobacco here. So think about the environment, think about peers, think about availability, think about exposure, and think about access that encourage tobacco use and encourage cannabis use. And those are all around us. You guys know cues and triggers, right? What do you think cues and triggers a tobacco user on a daily basis? Everything. Everything is a cue and everything is a trigger. The car, the coffee, the beer, the workplace, the family, advertisements, everything is a cue and everything is a trigger. And that sets up an automatic reaction in your brain. I got to tell you a story about a trigger. I ran a cocaine group for a while. And one night we were leaving and it was late and it had just snowed that night. And I walked out with the group members and the parking lot lights were on. It was dark and this layer of snow had just fallen and it was glistening. And if any of you have ever seen what powder cocaine looks like, it can look like that. And the group freaked out because of that snow. We actually had to stay a little while longer and deal with that cue and deal with that trigger. But this happens every day with a tobacco user, and not just the tobacco, but every other substance as well. Everything can be a cue, everything can be a trigger. Did you know that in minority communities, particularly African American communities, there's 10 times more tobacco advertising than there is in other places? And a lot of it is point of sale advertising. And there's so many more little shops that sell tobacco products in those communities. So talk about cues and talk about triggers. One of the things with cannabis and with tobacco is that there's a common route of administration for these drugs. So a tobacco user who experiments with cannabis may continue to use past experimentation because the experience of inhaling the smoke is more pleasant than a non-tobacco user. Interesting that tobacco users also experience more positive subjective reactions to cannabis and therefore continue to use it. So again, another link. Some of the effects, general alteration of conscious perception, euphoria, feelings of well-being, relaxation or stress reduction, increased appreciation of the arts, joviality, metacognition, introspection. You've heard people say when they're smoking pot, they're more creative. You know, when they're smoking pot and smoking tobacco at the same time, they're even more creative, or so they think. Use of both substances at the same time has an additive effect, so that greater pleasure is experienced. So there's more pleasure experienced from the cannabis, and there's more pleasure experienced from the tobacco. So that's why these things kind of always go together. And that's another reason, that's another argument for stopping both substances at the same time as well. Okay, what's a gateway? I mean, there's so many things that could be gateways, I suppose. But basically, it goes both ways. So teens who smoke are probably more likely to experiment with cannabis, but teens who use cannabis are also more likely to initiate tobacco. So it kind of has a reverse gateway, a gateway effect, and then a reverse gateway effect. And then depending on what factors that person was in. Okay, so the toll of comorbid use, obviously physical, physical, psychological, behavioral, mental health, and social. And just to remember that little conversation we had here about marijuana smoke and tobacco smoke, it's good to know that. You know, and actually there are some things that I used to teach and say to my students that, you know what, I want you to know this, but it's not necessarily good information to give to your clients, because it almost can be a reason to continue the use of that substance. So this is really kind of interesting. I wanted to just mention this. the endocannabinoid system. It's the name for a series of cell receptors that respond to certain types of molecules. And there's two main types of endocannabinoid molecules, named anandamide and 2-AG. So endocannabinoids are like the body's natural THC. In fact, anandamide was named from the Sanskrit ananda, which means bliss. So basically, anandamide means the bliss molecule. Endocannabinoids are important for the body's day-to-day functioning. They help regulate things like sleep, appetite, mood, pleasure and reward, pain, memory, and if it's disrupted, any one of these things can fall out of balance. But what's very interesting is that recent studies have shown that the endocannabinoid system plays a pivotal role in nicotine addiction. So there's mounting evidence that the ECS has a significant role in mediating the reinforcing and other addiction-related effects of nicotine. And this is exciting for researchers because it may be possible to find alternative ways to modulate the endocannabinoid system that may have implications for tobacco use disorder and even other drug addictions. So it's kind of neat. But it's kind of like newer stuff that people are looking at. Okay. These two go together a lot, don't they? Oh, remember Maine now has clean indoor air laws, but the olden days when you walked into a bar, and I remember doing that too. I mean, I grew up in the era where there were no clean indoor air laws. We never thought twice about it, but you know that like 46,000 people die every year of lung cancer caused by secondhand smoke? In fact, one of my colleagues in New York, an addictions counselor who, same era, and back then people smoked in your office, they smoked in the building. Then we sent them to the smoke eater room, that little room where you put the machine, and that did nothing at all. Then we sent them outside, but a lot of those people are experiencing tobacco-related illness because of that. Some of you in here may remember that you could smoke on airplanes at one time. And here's a little interesting side note. We did some training on the Mohawk Indian Reservation, which is right up near the Canadian border in northern New York. And when you drive onto the reservation, there's a big sign that says, "This is not New York state land. This is Mohawk land." So we saw it. We thought that was interesting. We went to a restaurant, and the hostess came out and said, "Smoking or not smoking?" And we're like, "What?" Because New York had a Clean Indoor Air Act. And we said, "Oh, yeah, we're on the reservation." So we said, "Smoking." So she brings us to this little room in the back. There's about 4 tables. And we go in there, and we sit down, and my colleague says, "Gee, looks like they put us in the non-peeing section of the pool." So it was kind of like obvious. So drinkers are more likely to smoke than non-drinkers. Smokers are more likely to report drinking alcohol than non-smokers. And alcohol and tobacco tend to be used at the same time, and they reinforce each other. So alcohol and tobacco potentiate each other's rewarding effects, right? So drinking is going to make your smoking more pleasurable. Smoking is going to make your drinking more pleasurable. Smoking reduces the sedative and intoxication effects of alcohol. Now I'm going to give you a little test here because Dr. Carpenter was talking about reinforcement, right? He was talking about positive reinforcement, right? You give somebody something and that behavior is likely to continue. What kind of reinforcement is this? If smoking reduces the sedative and intoxication effects of alcohol, so it takes something away that's unwanted, it's negative reinforcement. So there's positive reinforcement and there's negative reinforcement. Tobacco, nicotine tends to do that. That's why it's so compelling for people. It enhances the effects in one way and it takes away negative effects in another way. Alcohol increases cravings to smoke, and smoking increases alcohol cravings. So is that an argument for treating both of these disorders at the same time, trying to become abstinent from both of these at the same time? Because if you continue to smoke, you're more likely to relapse, not less likely. People who are dependent on alcohol are 3 times more likely to be smokers, and people who are dependent on tobacco are 4 times more likely to be dependent on alcohol. So you see the theme we got going here? We got cannabis. Now we have alcohol, how these things are interrelated and how they connect. Okay, what is the tobacco prevalence rate among patients with an alcohol use disorder? 80 to 90%. 19% general population. And people all the time, when I ask that question in groups like this, people all the time guess higher. All right, they guess 35, 40, 50. Why do you think that is? Because who do we have here, in this room, and what populations do you work with, that have very high prevalence of tobacco use disorder? And also, I go out, I work in Portland on Free Street, and I walk out to go get lunch. It seems to me like every person is smoking out there. It's just amazing. So we have that perception that it's much higher, but it really isn't. It's actually around 19% generally, but that varies among the state from about 17% to almost 30%. So some of the counties, some of the more rural counties, have very, very high rates of tobacco use. And identical twin studies. You take identical twins, you separate them, another genetic piece, you separate them, put them in different environments, different households, and they're almost equally as likely to develop alcohol use disorders because of that shared genetic factor. More than twice as likely than fraternal twins. Okay, tobacco and stimulants. So cocaine and amphetamines and that type of thing. Going to get the theme here again. Clinical studies suggest an interaction between nicotine and a variety of stimulants such as cocaine or methamphetamine and amphetamines. Reinforcing effects. Concurrent use of nicotine and cocaine enhances positive ratings of each drug. All right, so again, right, it's if you use cocaine and smoking, your smoking is more pleasurable, your cocaine is more pleasurable. Users report that nicotine enhances the reinforcing effects of cocaine. So you get a bigger high from cocaine, a better high. And then the interaction between nicotine and cocaine on extracellular dopamine is often described as additive. So higher amounts of dopamine can be produced when you use these two drugs together. So just what I talked about before, positive and negative reinforcement. So positive reinforcement serves to maintain nicotine-taking behavior. So you get something good, you get something positive, you get a reward for that behavior. And if you get a reward for that behavior, that means you're likely to repeat that behavior. But also, if you do something and that something negative is taken away, that's also reinforcement. So some people think negative reinforcement equals punishment, but it doesn't, right? It's still reinforcement. It's still as likely that behavior is going to continue. So nicotine also takes away some of those negative aspects of cocaine use, which is great for the user. So I get an enhanced effect, and some of those negative effects I don't get. So again, concurrent use. All right, is tobacco a gateway to stimulants? Well, studies have suggested that most cocaine users initiate cocaine use after a history of tobacco smoking and while still smoking cigarettes, which is really interesting. I don't know if you remember a movie, it was like maybe 15 years ago or 16 years ago. And the guy that played Batman was in the movie, one of those guys, and he was a cocaine addict, and there was a scene where he was smoking and using cocaine, and it just like, I saw that and I say, this is so typical. This is exactly what it's like for these users. All right, here we go. A little bit on opiates. True or false? There's no difference between opiates and opioids. This is just a little interesting factoid that I wanted to throw in here, so you can think about this, because it's the opioid crisis, right? The opioid crisis that we're talking about. Guess what? Heroin is not an opioid. What is heroin? Heroin's an opiate, right? Let me explain the difference. It really doesn't matter, actually, when it comes right down to it, because the effects are the same, whether it's an opioid or an opiate. But opiates are either naturally occurring derivatives of the poppy plant, so directly from them, like opium and morphine. Opioids are synthetic. They're fully synthetic, so we don't need the poppy plant to make an opioid. Fentanyl is an opioid, methadone is an opioid, but heroin is actually an opiate drug. So these are natural opiates. I think that might be the same picture that the doctor had. So, the first thing that you get from the poppy plant is opium. So you score the sides, you take a sharp knife, you score the sides, this liquid drips out, and then it gets hard and kind of brown and sticky, and you scrape that off, and that's opium. Then from opium, you have to do a little bit of a manufacturing, a little bit to derive the morphine from that. But codeine is there, and I have trouble with this one. I think it's thebaine is one of the natural occurring opiates, and then aripiprazole as well. The semi-synthetics, heroin. Look at the hydrocodone, hydromorphone, buprenorphine, which is also Subutex. So some of these prescription medications are also opiates and not opioid drugs. And then the synthetics are like methadone and Demerol and fentanyl are all. And just, it's not that important to know the difference between the two, but just it's interesting to know that information. So, this looks like the theme is continuing here. Smokers are 3 times more likely to report non-medical prescription opioid use than non-smokers. So if you smoke, you're 3 times more likely to abuse prescription meds. And there are positive associations between tobacco use disorders and opioid medication misuse. So if you have a tobacco use disorder, more likely to abuse prescription medications. Anybody in here from the methadone maintenance program? 95% of methadone maintained patients smoke cigarettes. And this could be a big issue because of what we've just been talking about, right? Because you're more likely to pick up your drug that you're trying to stop using if you're continuing to smoke. How long should someone stay on methadone? Doesn't matter, forever, they have to. Right? How long should someone stay on tobacco treatment medication? Forever. It doesn't matter if they have to. I love the conversation about chronic disease this morning because it's exactly the same thing. Would we ever say to somebody, you're using this insulin now, but I think you really need to titrate that down and get off that insulin because you can do that on your own. You don't need that medication. Or you know what, let's get rid of that asthma control medication that you're using. You really don't need that. It's the same concept, right? If addiction is a chronic disease, which it is, then we have to treat it as a chronic disease. And some people with chronic disease have to be maintained for their entire life on medication. Whether that medication is methadone or buprenorphine or Subutex or whatever it is, or whether it's nicotine replacement therapy or Chantix, or bupropion, which is another tobacco treatment medication, that's okay. We don't have to be telling people you need to stop using this medication.
But you got to tell the insurance companies to pay for it.
Someone always throws that wrench into it. Yes, that's true. Yep, you're absolutely right. And that's part of why this is a challenge. The insurance industry and all that stuff is a big challenge. So you can't go cold turkey on opiates any easier than going cold turkey on cigarettes or any other drug for that matter. So nicotine and opiates. Nicotine and opiates like heroin and morphine and opioids tend to increase total drug intake. So if you're smoking and using, you're going to use more of each. Heroin or methadone administration increases the amount smoked. So you're using heroin, you're going to smoke more. And methadone increases the subjective ratings of smoking satisfaction. And that's sort of an issue, right? Because we're trying to get people to stop smoking, but 95% or 93% of people who use methadone also smoke because using methadone actually makes it more pleasurable for them to smoke. So we got a little issue there. Okay, just some of the implications. I think we're doing well on time here. I'm not going to keep you from your food, which is dangerous. Nicotinic acetylcholine receptors. So these are the receptors in the brain that the nicotine acts on. But it also alters the reinforcing and rewarding effects of other drugs. So this nicotinic acetylcholine receptor system has implications in other addictions as well. So we have this complicated brain mechanism and brain chemistry that's working here. And the behavioral effects. So this is interesting. Nicotine enhances stimulant effects, right? It alleviates drug withdrawal. It alleviates drug-induced cognitive effects. So you can smoke pot and smoke cigarettes, and you're going to be less impaired by that pot. You're going to have less of a pot high if you smoke cigarettes. And it also enhances tolerance in terms of opioids. Does it look familiar? Just had that talk last time, okay, and I don't need to say anything about this because he did it beautifully. But using this strategy of motivational interviewing, open-ended questions and affirmations and reflections is the evidence-based practice for people who are not sure if they want to stop smoking or not, right? Because they have that level of ambivalence. And then once they decide that they want to quit, then you're moving more to a cognitive behavioral approach, because that's where you're analyzing your behavior, you're doing that chain analysis, and you're learning skills in that CBT approach. But 8 out of 10 people are not ready to quit. This is what helps them to get ready. So you can do this with your patients and with your clients. You can use this strategy, and you will help them to move up that readiness ladder until they kind of come out of that. Some would call it the contemplation stage of change, until they come out of that and enter that preparation stage. So I like scaling questions. So asking people about, are you ready to quit, is not as good as saying on a scale of 1 to 10, how important is it for you to quit? That's an open-ended question, right? What made you choose that number? How confident do you feel on the same scale? So having conversations like this with people can be really useful in helping them to kind of move along that ladder, that confidence ladder. And this is almost verbatim from what Dr. Carpenter was talking about, asking permission, before giving advice. Being curious. I like the Columbo example. You guys remember Columbo, the TV detective? And he was kind of bumbling, but he was always asking questions, and he was scratching his head. And he goes, just one more thing I want to know. He was always curious, and that's a good way to be with people. You're asking about them. You're not telling them what to do or what they should do. You're asking about them. And don't use fear or don't use threats, and don't give information with the intent to shame or blame. I had a young lady tell me, I was talking to nursing students up at UMaine, and she was in her doctor's office, and the doctor said to her, if you were a good parent, you would stop smoking. And I said, how'd you feel? And she said, I felt like crap, I just wanted to get out of there. So that is not the approach to use. And don't shame or blame people. All right, a couple of studies I wanted to share with you. Treating tobacco concurrently with alcohol and drug addiction treatment. We know this is the right thing to do now. For many, many years, I was telling people the wrong thing to do. I'm trying to rectify that situation by sharing information with you. It doesn't jeopardize abstinence. All right, stopping smoking does not jeopardize abstinence from alcohol or other drugs. And this is 2017 studies that when smokers keep smoking while trying to quit, they're more likely to relapse to their substance abuse. It doesn't lead to an increase in other drug use, and it actually improves outcomes. It improves short-term treatment outcomes and long-term recovery outcomes. Okay, medication strategy. So interestingly enough, treatment for tobacco using the FDA-approved tobacco treatment medications may decrease the use of other abused substances. It can also enhance treatment outcomes. So just treating somebody with tobacco treatment medications can have a positive impact on their recovery from other substances. And we're trying to, there's a lot of research going on in this area right now. But I wanted to share the evidence-based practices with you, or the evidence-based medications with you. There are 7 FDA first-line medications, safe, effective, and research-based. And the only one that's not listed on here is a lozenge, because the gum and the lozenge are pretty much the same. But the patch, the gum, the nicotine inhaler, the nicotine nasal spray, and then 2 non-nicotine medications, which are varenicline, which is Chantix, and bupropion, which is most widely known as Wellbutrin, but it's also called Zyban for tobacco treatment. And if you look at the estimated abstinence rates, 3 to 4% cold turkey, 13.8% placebo, so there's even a placebo effect. But if you look at varenicline, 33.2. So it's a definite difference. So everybody should be offered these tobacco treatment medications. And we're talking about combination medications a lot too now. In fact, there's some recommendations that you go right to combination medications first. So you use almost an asthma model. In asthma, there's a control medication and there's a rescue medication. With tobacco, it's like you can do the same thing. The control medication would be your patch, because your patch is a long-acting NRT, while the others are short-acting. So combining the patch with the gum or combining the patch with the lozenge can be very, very effective. How are we doing? Okay. Just to show you some pictures. The patch, the gum, and the lozenge are over the counter, and the inhaler and the spray are prescription. Here's some exciting news. Anybody know LD 455? Legislative Document 455. Anybody familiar with that? Right. What that is a law which has been passed, which is going to allow pharmacists to write the order for nicotine replacement therapy for people just coming in, people with main care, right, who just come into their pharmacy. Prior to this, they had to go to their doctor, they had to make an appointment, they had to get a prescription from their doctor for the NRTs. And we're going to eliminate that step because there's obvious problems with that. Some people don't have doctors, or they don't have access to their doctors. They have to wait a long time for that to happen. But it's a very exciting new development that we're very happy about. So what you're going to hear people say is, that didn't work. I tried that patch. It didn't work. I tried the gum. It didn't work. There's 3 questions that you want to ask somebody if they tell you their medication didn't work. The first question is, how did you use it? All right, because a lot of people use it incorrectly. All right, I had a guy say, the patch didn't work, and I said, how did you use it? He said, well, I put it on the sole of my foot. Then I put some tape around it, but it didn't work. It didn't help. And so I explained to him that that's really not the right way to use it. Use it above the waist, on the arm, on the torso, somewhere. And how much did you use? And he was smoking 20 cigarettes a day, and he was using the 7 milligram patch. Anybody see a problem with that? You know why that's a problem? Because each cigarette gives you about 1 milligram, give or take, of nicotine. And when you do nicotine replacement therapy, it's 1-to-1. Right, so we want to give you 20 milligrams about, if you're smoking a pack per day, so you should be using the 21 milligram patch. Oh, okay, I get it. And how long did you use it? Well, I used it for 2 weeks, and the recommended time is 8 to 12 or forever, right, depending on how long you might need to use it. So the 3 main reasons people will say it didn't work: they didn't use it right, they didn't use enough, or they didn't use it long enough. Can you put 2 patches on? Is that okay? Is that safe? Yeah, it is. You can put 4 patches on. I had a colleague in New York came in with 4 patches lined up her arm because that's what she needed. Right? Is a 21 milligram patch going to work on someone who smokes 2 packs a day? No. Right? They're going to need 2 21 milligram patches. Nicotine replacement therapy is very safe. Right? The olden days, we got all freaked out if someone smoked a cigarette and they had a patch on. They're going to have a seizure. They're going to have a heart attack. No, that's not going to happen. Right, the spray and the inhaler are less popular. The patches, 80% of people who use NRT use the patch. All right, they decrease withdrawal symptoms and cravings, and they can more than double quit rates. Now, the 2 non-nicotine medications, bupropion is an antidepressant. We found out by accident that this worked in a veteran study in California a number of years ago. That were using bupropion in a depression study, and a lot of the patients didn't feel like smoking. So we studied it for tobacco, and yeah, it works. It's a reuptake inhibitor, like works in a dopamine reuptake area. And varenicline, which is the most effective medication, is actually an nicotine receptor agonist, partial agonist. And they talked a little bit, doctors talked about agonists and antagonists. It's a nicotine receptor agonist, so it partially stimulates that receptor, but it also has a higher affinity for the nicotine receptor than the actual nicotine does, so it will bind to that receptor, thereby blocking any nicotine from getting there. So it's a very effective medication. Also, the black box warning has been removed from both of these medications. There was a big study done, 8,000 clients, on psychiatric symptoms after using Chantix and using bupropion. And the outcome of the study is there no more psychiatric symptoms in the control group than in the group that used the medications. So still need to use caution in people who have history of mental health disorders or psychiatric disorders, but it means it's much, much safer than we thought. So there's a bunch of references if you wanted to, I think you can go online and get this stuff if you want to, right? Yeah. Okay, so thoughts, comments, questions? All righty, thank you.